Hi, welcome to everyone in the room. And thank you so much to the many folks joining us online. On behalf of the Center for American Progress, we appreciate your being with us today for a conversation that we are thrilled to be hosting. A quick bit of housekeeping, we are hoping to have some time for Q&A. So if you have a question, we ask that you write it down on your note card, raise it up into the air, and we'll collect it. My colleague Nicole, who is right over there waving, will be collecting cards up until about 3:20. And we likely won't be able to get to all the questions, but we will plan to raise a few up for the secretary. For the folks online, we are actively monitoring the Zoom, so please feel free to submit any questions you might have through the Q&A function. And finally, for those of us in the room, if you could please take a minute to silence or turn off your cell phone, that would be greatly appreciated. Thank you. So with that, welcome again. I am CAP's Vice President of Health Policy, and I have the privilege of directing a fantastic team of experts working to advance access to health coverage, make healthcare more affordable, and improve public health and health equity. One of the ways that we do that is by trying to tailor healthcare policy changes to solve for the real challenges that weigh most heavily on Americans. As we all know, affording prescription drugs is high on that list for many people. This is especially true for older adults, like those on Medicare, who tend to have more healthcare needs and live on more limited incomes. And why is this a problem? Because prescription drug prices in America are unconscionably high. For decades, those high prices have led to inequitable healthcare access, and as a result, older Black and Latino adults are roughly twice as likely as their white peers to say they don't fill all the prescriptions they need because of the cost. When your life depends on consistent access to medicines, that is simply unacceptable. Fortunately, the country has a bold leader in the Biden administration and a president who has exhibited tremendous courage taking on big pharma. That hasn't been easy, but it has been so critical, and this commitment is already paying off for millions of people. Over the past couple of years, with particular thanks to the Inflation Reduction Act, historic reforms to the Medicare prescription drug costs are delivering real results and are poised to narrow health equity gaps. Among these reforms is the power the government now has for the very first time to negotiate prescription drug prices, a monumental policy achievement that we expect will cut the prices Medicare pays for drugs in half. But the Inflation Reduction Act also delivered a number of other important out-of-pocket affordability wins that are already providing relief to millions. For example, capping insulin costs at $35 a month was a game changer for my father-in-law. A few years back, my husband and I were dismayed to learn that he stopped filling his insulin prescription when he would hit the point in his Medicare coverage that required him to pay an exorbitant amount for refills. And he was not an outlier. We also know that people who have some of the most significant prescription drug needs are already saving thousands of dollars this year, thanks to the new out-of-pocket spending cap for Medicare Part D. I could not be more personally grateful for these reforms, nor happier for the direction the country is headed in on lowering prescription drug costs. I am so excited to introduce a phenomenal leader who has been critical to implementing these historic changes and whom we are honored to host in conversation with CAP's President and CEO, Patrick Gaspard. Please join me in welcoming to the stage Patrick Gaspard and United States Secretary of Health and Human Services, Xavier Becerra.
Good afternoon, everyone. Mr. Secretary, welcome to the Center for American Progress.
Patrick, glad we were able to do this.
Same. I've had the privilege of calling you Congressman, calling you Mr. Chairman, calling you Attorney General. It feels fantastic to call you Mr. Secretary. Now, you should know that you are actually the first sitting cabinet secretary who has graced us with their presence in our new event space. So you're kind of, like breaking the champagne bottle over the ship right now.
Yeah, but where's the champagne?
That comes off camera, sir.
Okay.
So I've very much been looking forward to this conversation, and not only because of all of the things that Andrea just said about the importance of this issue and the crisis of affordability in medicines in America, but most especially because you're one of my favorite public servants. It's been an honor to be able to serve with you in the past, and because I think that you just have a unique journey and a unique story. I once heard you say, I didn't come into public service in order to be part of a system that excludes. I wonder how you meant that and how you can connect your own journey to why this issue has become so integral for your service.
First, Patrick, to you, to the center, for all the team at the center, for everything you all do all the time. It's fantastic. You know, when you've been around long enough, you do develop these friendships and relationships with people who are always there. It's, you know, there's a foxhole and there's a major battle going on. You jump in the foxhole, who you find? Patrick Gaspard. You know, it's no longer coincidence and no longer strange. It's intentional when you see a lot of the same people in that same fight. And it really makes you feel good because we've been around doing this for quite some time. So thanks to you, to your team, and thanks for all the work you've done before you were at the center as well. So I'll try to be brief in the story. Freshman year in Congress, 1993, we're in a recession. Bill Clinton is president. Democrats actually controlled the House and the Senate. By the way, we control the House. You know, right now the margins are, 220, 216, that kind of thing. There were 268 Democrats in the House of Representatives when I got elected in 1993. We could not pass a budget with 268 Democrats. That's the chaos and confusion that existed with Democrats at the time. So the story is this. We're trying to provide relief to unemployed Americans who'd been unemployed longer than their benefits ran. So we were going to extend the benefits, needed $4 billion to extend the benefits. So we had to cobble together, leadership had to cobble together money. Ways and Means Committee, Dan Rostenkowski was the chairman at the time, one of the so-called bulls at that time. They were very powerful chairmen, not like today. Put together a bill, $4 billion, it was going to hit the floor. I like minutia, so I read the bills and I saw that one of the ways we were paying for that was $1 billion was going to come out of folks on SSI. And if you're familiar with SSI, it's supplemental security income. It is not Social Security. It is a program for those who are low income. So it supplements your income. And I said, why would we do that? And as I read further, it wasn't just anybody on SSI. It was only immigrants who are on SSI. And to be on SSI, you cannot be undocumented. You have to be legally here. So the folks that we were going to take $1 billion out of were people who were poor, who needed supplemental security income, but only if they were legal immigrants. I thought to myself, and I'm the son of immigrants, why would we do that? So I went to the speaker, Tom Foley at the time. I said, this doesn't make sense. Why would we do that? We're trying to help Americans who are unemployed. I get that. But why would we help people who are poor, worked, paid their taxes, done it legally? Why are we going to make them pay the price? Well, we had to find the money. I didn't feel good. I was a freshman member, started speaking Hispanic caucus, started reaching out to Black caucus, Progressive caucus. Pretty soon I was able to get enough folks to say, yeah, couldn't we find a different way to do this? Enough that I was able to get to leadership. And the bill was going on the floor. They had to pull the bill. We had one of those C-SPAN moments where nothing was happening. And it's because the bill got pulled and unexpectedly. Next day I hear they're going to try to take that cut out, come up with something else. I was thrilled. I went to the Democratic whip meeting. I was a freshman whip, and I raised my hand, wanted to thank the leadership for what they'd done. They'd come up with a new fix, didn't cut the money out of legal immigrants, waited my turn, was starting to say my piece. And in those days, the room was very full. All the chairs sat in big chairs. All the chairs of committee sat in these big chairs along with the speaker and the Democratic leadership. The rest of us minions sort of sat around, and I was talking, and as I'm saying, thank you very much, Mr. Speaker, to the leadership, et cetera. Dan Rostenkowski, you may be too young to remember that. Dan Rostenkowski was a very powerful chairman of the Ways and Means Committee. He turns around and he says, goddamn legal immigrants, we're sacrificing Americans for immigrants. And I said, Mr. Chairman, these folks are legally here. They pay taxes. They've done everything the right way. And and he started, and I had the floor. I learned really quickly, when you have the floor, you have the floor. You know. So I said, they're paying their due. They're entitled to be able to receive the benefits of what they've done. And so, speaker cuts it off. Finish up. I'm walking out of the room. Start having people come up to me and say, Javier, what did you just do? I said, well, what do you mean? He said, you just upset the chairman of the Ways and Means Committee. I said, no, I had the floor. I just was explaining to him. You shouldn't have done that. I said, oh, come on. Next day I find out Chairman's railing saying he's going to pull his own bill that had fixed the cut and he was going to reinsert the cut for next week. I said, no, he's not going to do that. Next week comes, he reinserted the cut. I ended up voting for the bill. I say that because I won, but I lost. But I think overall I won because Dan Rostenkowski ended up going to jail and I ended up getting on the Ways and Means Committee. And but you gotta be willing to get in the foxhole because man, did I feel badly. Gosh, did I not want to vote for that bill? But we needed to get money to unemployed Americans. So I voted for the bill. You learn a lot of lessons in life. But one thing you learn is you got to always fight and hold your ground if your ground is your values. And that's something that my parents taught me. They never had much. My dad started working when he left the 6th grade because he was the oldest of 8 kids. He married my mom, brought her from Guadalajara, Jalisco, Mexico when she was 18. They didn't have much. We did what we could. Thank God he was a member of the laborers union. That meant we had health insurance coverage. But otherwise, we struggled. And to me, folks who work hard, do things by the rules, should never have to face these cuts that come simply because they're easy targets. And so I have always taken this position that if I have a chance to be in a place to make a difference, I have 2 mottos: never do mild and never do it alone. And so that's what I take with me wherever I go.
So I really believe that biography matters in public policy making, but I ultimately believe that character is destiny. It's true for you, true for Dan Rostenkowski as well, apparently. But in that story, you talked about how you love the minutia, and I think that we don't understand sometimes that we have to do the unsexy work of diving into the minutia if we're going to make change in the world. I want you to pull back for a second and give us the landscape on prescription drugs in America today. Who exactly is getting the drugs that they need and who's not able to get the drugs? And you're in a think tank, so don't be afraid of throwing out some data here.
So we have the most vibrant pharmaceutical industry in the world here. And if they're not here, they want to get in here. We also have the most expensive pharmaceutical market in the world here in the US. Even though some of those drugs are made here, they cost us 2 or 3 times what they cost other people in other parts of the world for the same drug. Americans are making decisions because of that. It is the American who's on a fixed income, relies on Social Security, who has to make a big decision. The couple that I met in New Mexico, the husband had suffered a stroke, was still trying to recover from his left side. He had a vision condition that the doctors had said, look, we can take care of that with some medication and it'll help you improve quicker. And so they were ready to go until they found out they had a leaky roof. And so they had a leaky roof, improved health conditions and vision. They chose the roof. Americans are doing that every day. Some Americans are cutting their pills in half so they can extend them to the end of the month until they get the money to buy the next month's worth of drugs. And by law, we could not do anything to try to negotiate to get better prices, at least in the government programs like Medicare. And finally, Congress passed Inflation Reduction Act. President Biden pushed for it. And today we are sitting down with the manufacturers of the 10 most expensive drugs in Medicare, which those 10 drugs alone in 2022 cost Americans and Medicare program $46 billion. We're right now sitting down and negotiating with all 10. They're suing, all 10 of them are suing me at the same time.
So you're
sitting down and negotiating.
So that was going to be part of my next question. But before we get into the fight, can you just help us understand how it's possible that an American pharmaceutical firm can produce drugs here in the United States and charge less overseas for those drugs than they charge their fellow Americans?
Patrick, I'd like to explain it, but I don't think I could come up with a logical explanation other than you can make money. And because you can drive the market, you get to do what you want to do. It's like the bully who would come up to you and say, you got some lunch money today? You got to make a decision. And these guys have done a great job of bullying in Congress and elsewhere, and they get their way. So much so that there was a law that forbid us to try to, on behalf of 66 million Americans in Medicare, negotiate to get a better price. Who would not want to have business with me if I have 66 million customers just waiting? Yeah, you do say, who's going to give me the best offer? And I'm going to give you access to 66 million customers. I couldn't do that. Now I can. That's why they're sitting with me at the same time that they're suing me. Come September 1st, stay tuned because we'll announce the prices.
So we're all staying tuned. We're gonna rock up for that announcement. But give us an understanding of what these 10 drugs are and why these drugs matter specifically for health equity. You've said that you want to move the United States from an illness care system to a wellness care system. How does that apply in the context of these 10 drugs?
Yeah, I mean, if you're rationing your drugs, you're not doing what your physician told you to do. If you can't buy the drugs, you're obviously not going to improve your health. And so we need to get to a point where people aren't making decisions based on economics versus their health. But that's where we are in this country because we treat healthcare as a commodity, goes to the highest bidder. And we don't do that with water. We don't do that with public education. We don't do that with electricity. It's regulated. But something as indispensable as health, we let it go to the highest bidder. And so today you have Americans who are rationing their care, not because that's what the physician said to do, it's because they have no choice. And you have too many people. I had a senior come to me in Dallas. Her name was, I'll remember her name in a second. She had a great story. This was January of 2023. The Inflation Reduction Act provision had just kicked in on insulin. And she says to me, December, I paid about $117 for my insulin. January, I walked in to get my month's supply. And I walked out of the pharmacy like I always do. And I looked at my bill and I said, pharmacist made a mistake. Gosh, I feel guilty. I can't keep the money. She went back. She told the pharmacist, you underbilled me. And he said, no, that's the new price. It's no longer 117, it's $35. For a woman, as she was a Black American, a woman who lives on her Social Security check, that's big money. That's big money. The drugs we're now negotiating for are essentially the ones that tackle diet. I'm not going to market and advertise for the drug companies on the names of the drugs, but
I hear that they have really great advertising resources. So I think that's covered.
They do. And we took that into account, by the way, in our negotiated price. Diabetes, it's all the usual suspects: diabetes, heart disease, stroke, cancer, chronic kidney disease. You know, the chronic diseases that are costing America the most and are killing Americans the fastest.
The things that sit in the space of comorbidities that we heard so much about during the course of the pandemic.
Which during Minority Health Month, I should mention, are the ones that kill Black and brown folks most.
Yep. So you're at the table, you're negotiating over the prices for these drugs, but some of us noted that even before you set the terms of the negotiation, 10 lawsuits dropped down. And I think they all named you personally in them. And, you know, they came from the pharmaceutical lobby, they came from the Chamber of Commerce, companies like Merck. It was an astonishing thing to see even before you set the terms of the negotiation. So I wonder if you'll say something about, and I know that you can't talk about the terms of individual suits that are ongoing, but if you just say something about the scale, the enormity of the power that you and the president and our partners in government are up against in this make or break moment for working families.
You just have to go down the street to the Capitol to see them in action. They are extremely effective. They hire very talented people to go out there and advocate, read, lobby, and it's very effective. And by the way, it's a very important industry. Let's not disregard that. We want the pharmaceutical industry to be here because we want to have the greatest inventions, the greatest new medicines to be available here as fast as possible. And we also want to be able to make them available to as many people as possible. So we want them to succeed. And by the way, our negotiations make that very clear that they're important, they're indispensable to the way of American life and health. But at the same time, as you mentioned, they are trying to stop us from doing what we're doing. So we're going to move forward. So far, the courts have sided with us. Maybe they're trying to pay me back for having sued the previous administration 122 times when I was the attorney general for the state of California. I don't know.
That's great. I appreciate all that you said about the pharmaceutical industry. These are terribly important companies, and we want to incentivize innovation in this space and growth in the space. I will note, as somebody who has been a champion over time for things like the PEPFAR program, which is a shining example of how America leads in global health. One of the critical successes of that program was our ability to help negotiate drug prices down in sub-Saharan Africa, for instance, while we couldn't even do that here in the U.S. So I don't want to. I want to make sure everyone here and those online really appreciate the extent of the absolute transformation that you and the president have led with in this space. On the question of transformation, and since I touched a little bit on the pandemic, I wonder if you will just talk about the specific provisions around free vaccine dissemination that are part of this discussion and the legislation, and the importance of the vaccine provision in the course of your work on health equity.
So, Patrick, I think folks will remember when President Biden was campaigning as candidate Biden, one of the things he said on healthcare is his goal was to lower the cost for more people with better care. Lower the cost, $35 insulin, $35 asthma inhaler. Lower the cost, negotiations for prescription drugs. He's doing that. Lower the cost. Today, if you look at the Affordable Care Act website for the marketplace, you can find 4 out of 5 people when they log on to healthcare.gov and look for a health insurance plan, 4 out of 5 are finding a plan that costs them $10 or less a month in premiums. I'm going to say that one more time because folks are going to let it fly right by them. Because some of you bought coffee today, and I bet you used up half the cost of a month's worth of coverage under the Affordable Care Act. Some of you want to go see a movie this weekend. You're going to spend way more than a month of full coverage, real coverage under the Affordable Care Act, $10 a month or less. He's lowered the cost. More people today in America, there are more people who have access to a doctor, can send their child to a hospital and not worry about going bankrupt because they have their own health insurance, public or private, but they've got their own insurance. Never in the history of the United States of America have more than 300 million people had their own insurance. Today they do, and that's why they can have the peace of mind. That's Joe Biden in action saying, I'm going to lower the cost for more people. And as I said, with better benefits. That's going on right now as we speak. And the reason we're doing that is because the president doesn't like when you leave people out. And that's why today I could tell you for the first time in our lifetime, and actually in the history of this country, close to 700 million COVID vaccine shots have gone into the arms of Americans. And not one person has had to pay 1 penny for any one of those 700 million vaccines. And if you think, and so, I always say this, Patrick, people hear the numbers and sometimes they're big, right? They fly past you, 700 million shots. Multiply that by probably $1,000 is what it would have cost if that were out there. You were having to bid for it in the private market. Now, here's the kicker. A lot of folks could pay $1,000 to get that vaccine, and they would have. A lot of folks could not. When I came into office in March of 2021, I started getting, we were right in the midst of COVID, right? Starting to get the reports, and you could already see what always happens in this country. We started to see the disparity grow. By May or so of 2021, about 2/3 of white adult Americans had received their first COVID vaccine. Less than 50% of Black, less than 50% of Latino adults at that point had received their COVID vaccine. And we said, and I absolutely said, like I said when I was in Congress, this is not going to happen. This shouldn't happen. We know how to do this. We can't wait for folks to come to us. We got to go to where they are because some of these folks can't leave work. Some of these folks have to take care of kids. Some of these folks will lose their job if they try to leave to go get vaccinated. And some of these folks live in really distant places, don't have transportation. So we started going where folks were. We started using trusted voices, the clergyman person, the wrestling coach, the barber. We went where people would trust the voice. And by the beginning of 2022, more than 90% of white adult Americans had received at least one vaccine. More than 90% of Black adult Americans had received a vaccine. More than 90% of Latino adult Americans had received a vaccine. More than 90% of Asian American, Native American adults had received. We had erased the disparity, not because we got lucky or it was coincidental or that it was easy. It was intentional. President Biden gave us direction. Go out there and reach people. So the reason we're breaking records on the number of people who are insured, the reason we've been able to get so many folks vaccinated is because when people know that there's something really good out there, they'll buy it. You just got to let them know. And for too long in America, we haven't let communities know that there's something that they can get and that they're entitled to.
In all of your leadership roles, I've always found you to be a phenomenal storyteller because you don't start in the place of policy. You always start from the place of values, and then you move into the data and the policy work. You just said a number of things about what it means to exclude, to leave some folks behind. Speaking of folks who often get left behind, Americans with disabilities and older Americans who qualify for Medicare often have low incomes. There's a provision in IRA that expands eligibility for Medicare Part D, the part that covers prescription drugs. Can you help us to understand what that expansion looks like specifically and who's now eligible in that space?
So the Inflation Reduction Act had some great provisions. Everyone knows about the insulin for $35 or less. Everyone now knows or beginning to learn about the negotiation for better drug prices, but we also have a provision in there that expands the low-income subsidy program in Medicare for Americans who are lower income. There are Americans who are paying more for their Medicare than they need to because they're not aware that they get subsidies to have zero copays, zero coinsurance, zero premiums, yet they're putting money out of pocket. And the folks that should know, the providers, should be able to say, wait a minute, you're pretty low income. I think you qualify for this program. You don't have to fork money out of your pocket to cover the cost of this particular visit or that particular medication. Too many folks, again, mostly in communities of color, mostly in rural America, are the ones that are losing out. There's also in a provision in the law that's now kicking in. Part of it's kicked in already, but the one that's really going to be good is next year, which caps the entire amount that you will have to pay out of pocket in Medicare for your prescription drugs to $2,000. Some of you are going to say, $2,000, that's a ton of money. If you're on cancer drugs, if you are on heart disease drugs, if you are on chronic kidney failure drugs, you are paying a ton more money than that every month. But starting next year, no one in Medicare will have to fork out more than $2,000 in a year for those drugs. That means they're going to have a lot of income in their hands, in their pockets as a result of not having to do that. That's one of the greatest features of this law that has yet to even kick in.
Mr. Secretary, I'm going to abuse the privilege of having the microphone in my hand, and I'm going to turn this open to the audience for their questions, but I'm going to ask one last question and just abuse this a little longer. So you're a history maker. You're the first Latino in the history of the nation to become the secretary in this role that you're in right now. And I wonder, from the perspective of that history, and given the fact that you just completed a Latino health tour where I think you just came to 7 cities in 7 days, kind of heroic. Can you just talk to us specifically about the impact of all of these issues on the Latino and Hispanic community in America, and then also help us understand what you're doing beyond IRA provisions to lower costs and create greater access?
And quite honestly, what I'm about to say about the Latino community applies to most communities that have always been sort of on the margins because they get less information, they have less income, they're last to learn about something. And so it impacts a lot of folks. So if you're in a minority community, if you live in a rural part of the country, much of what I'm about to say applies. What I find as I go into the Latino community is so many people are saying, really, you're negotiating to lower drug prices? I can get $35 insulin? You mean I don't have to pay out of pocket more than $2,000? They don't know. When I tell them, you probably qualify to get a health insurance plan for you and your family that's going to cost you pennies on what you think, $10 a month or less in some cases. They have no concept. And you and I probably in this Melu think, oh, of course they should know. A lot of folks don't know. It's just, it doesn't get to them because their sources of information are far different. If you're working two jobs, if you don't speak really good English, if you have to worry about what's going on with your kids, so the only news you care about is what's going on at the school, you're not going to be in touch so much. And by the way, sometimes when you are, it's the social media platforms that get you information, and sometimes they're not so reliable. So it's the disconnect that occurs with so many folks. But here's what I will tell you. The disconnect does engender distrust. One of the biggest things we encountered in the Black community is we were trying to get folks vaccinated. They're saying, you want to sell me that? Let me tell you a story about Tuskegee, and let me explain to you why you're not going anywhere with that vaccine with me. Now, what happened to some service members, Black service members during, the World War II and so forth era was despicable when we used them as guinea pigs on sexually transmitted diseases without telling them. But that's like 80 years ago, 60 years ago. Nobody really remembers that unless you're from the Black community, because that story gets shared all the time because somebody's grandfather, somebody's uncle was among those. And that's what they remember. You're giving me something free? I get it. I know what you want. And you have to be able to break that cycle of suspicion. And so you got to really work hard. So when you go to some of these communities, I didn't know I could get a policy, health insurance policy for $10 or less. It's not that they're ignorant and they're not trying. It's that their world, they're having so much to do. We take for granted how much information we get easily, freely. We have to work hard because when for generations we've ignored them, you shouldn't expect in one visit that you're going to overcome that. That's the same thing, by the way, with the vote. Folks say, now you want me because the vote's coming up, so now you come visit me. A lot of folks say, come visit me after the election, so I know that you really meant it, that you really care about me.
You sound like somebody who's had to run for office before.
Yeah.
Mr. Secretary, let's open this up and have a little bit of fun, please.
So I have three excellent questions here from the audience. Thank you for sharing them. The first one is, some drug companies say that these changes will blunt pharmaceutical innovation. Do you buy that argument?
Never have, and I won't now. But here's the reason we don't need to, because under the law, the pharmaceutical companies, if they want to negotiate, had to provide us with information about their drug, about their process, and information that we could use to sort of come up with a fair price. Among the data points that they provided was information about their research, their investments. We get to factor all that in coming up with a fair price. So we're not closing our eyes and saying you didn't spend $1 to research this product to bring it to market. We're taking into account everything they give us. And I think at the end of the day, it'll be clear that we shouldn't be the chumps who pay high prices so that pharmaceuticals can sell their products elsewhere for less price. And we should be able to get it for a competitive price. No one here, I hope not, well, maybe because of the supply chain issues. But when I go to a car dealership, I don't walk in and look at the sticker price and say, okay, I better pull out the checkbook. That's what I'm going to pay, this sticker price. No, you go in there and you say, I read it. Here's my consumer reports. Here's the blue book. this is what I'm willing to give you. And then the dealer comes back after 20 minutes and gives you another price, and you negotiate, right? You do go to flea market. You don't pay the price that you negotiate. That's as American as apple pie, competition. We're going to do that. And we're going to take into account what you spent, what you invested to manufacture that drug. Fair. But we're not going to pay you 2 or 3 times what you charge folks in the rest of the world. Let's come up with a fair price.
So here's the second one. Given Big Pharma's vehement opposition to the drug price reforms in the IRA, what's at stake for Latinos and communities of color as drug companies and their allies try to repeal the drug price law, in particular the provision giving Medicare the authority to negotiate lower drug
So
prices?
this is the moment that allows you to show the fight in you.
No, look, I think I've pretty much answered the question. It's not just good for Latinos or poor or minority community. It's good for everybody. The couple I mentioned about the roof, they were white, and they had to make a decision between the medication to help the husband recover from the stroke faster, or fix the roof. They fixed the roof. This is hitting all Americans. You don't want to pay a high price for eggs or milk. Why would you want to pay a high price for prescription drugs if you don't need to? If somebody across the street is selling eggs for less, you're going to take your business across the street, so long as they're, good quality, they've been preserved well and so forth. If someone across the street is selling a prescription drug for less, and it's safe and effective, it's the same thing. Why would you pay the higher price? All we're just saying is, give us a price the way you give the folks across the street or across the ocean. Give us a good price. Now, we're going to base what we do on what happens here in this country, but it doesn't explain why those drugs in other parts of the world, even Canada or Mexico, cost way less than they cost here. We can negotiate a price based on what happens in America. That's what we're going to do. We're going to take all that information. We're going to come up with a fair price based on all the information the drug companies give us and what we think would be a fair price, and then go through as we are right now, this negotiating process.
So last month, the president released his budget, which proposed extending some of this drug price relief to even more people outside of Medicare. Will you share a bit more about what was in that budget?
Right. So everything I've been talking about, prescription drug negotiations, insulin for $35, cap to $2,000 on your out-of-pocket expenses for your drugs. That's good in Medicare. 66 million people in Medicare, 332 million people in the United States of America. That means you've got a whole bunch of Americans who don't get those same protections under the law. President Biden is saying, is there any reason why your mother should be able to buy insulin for $35, but your sister has to pay $200? Is there any reason why when your dad hits the $2,000 out-of-pocket spending for his medications, it stops there at $2,000, whereas your brother, who also is in need because of his cancer to buy similar drugs, keeps paying $10,000, $20,000, $30,000? Why tale of two cities in America that we should treat some Americans better than others, unless it's artificially done because of our laws that don't let us come up with the best price? So President Biden has said, is there any reason why we shouldn't extend this law so that it covers every American, not just Americans on Medicare? And he's also said, is there any reason why we can only negotiate 10 drugs this year, 15 drugs next year, and 15 drugs a year after? Why not? There are thousands of drugs on that Medicare makes available to its beneficiaries. Why not negotiate, as the president said, 50 drugs every year, so we get closer to getting all those drugs at a fair price? That's what he's trying to do.
Mr. Secretary, you just did the 7 cities in 7 days. I know that you've traveled every corner of this country, making the case, taking up the advocacy around these issues, constantly seeing you and others in the media. Why do you think that there's such little penetration around exactly what's at stake, what's being done, what the fight is, and who the folks are who are trying to stop progress. There's so little awareness. And I heard what you said before about people being busy. They have other things going on in their lives, but I want you to put on your old hat of somebody who actually used to have to be out on the hustings to get votes. Help us understand where people are at in their lives in America right now that makes it difficult for us to break through. And what do all of us need to be doing differently in order to crystallize what's at stake here?
I'm gonna be honest. I'd rather you answer that because I don't have the answer why it's been so difficult to have these successes penetrate into the public's mind. It's like so many things until it's right in front of you or until it hits you, you don't see it, you don't feel it. You remember when AIDS, HIV started getting big, you couldn't ignore it in the 70s. Remember there were people who were saying that's God's punishment for all these folks. And it wasn't until it was my son has this thing. All of a sudden it's like, what can we do? Can you please find a cure? All of a sudden you didn't care about, what your religion was. You wanted to save your son's life. Well, today in America, I think everyone says AIDS, HIV, absolutely, we should do whatever we can. That cocktail that keeps you alive should be available to everybody. We see Magic Johnson, who's still out there looking big and strong. And we think to ourselves, yeah, that's where we got to go. But it took a while because if you remember in the 70s, yeah, it was a sin. That was God's punishment. It takes a while. There's something called 988. Has anyone heard of 988? Some of you heard of 988. See, some of you probably haven't. 98, you should know about 988. You may not need it, but you should know about it. It's 911 for mental health crises. So you don't have to call 911. A lot of folks don't want to call 911 when they're experiencing a mental health crisis because they don't want law enforcement to show up. 988 is what we stood up nationally so you wouldn't have to remember what the regional 10-digit phone number was so you can get some crisis help. And it's working. About 8.5 million people reached out using 988 in the first year and a half of its operation. That's great that they're reaching out. It's horrible that 8.5 million people felt so desperate that they're calling 988. And we're not helping enough of them. But we got to get the word out on 988 because it's a great tool that you can use. We got to get the information out about insulin for $35. We got to get the information about the low-income subsidy in Medicare so you don't have to pay extra money. Patrick, why it doesn't penetrate faster? Part of it is that everyone gets their news in different ways now. Most young people don't really rely on the traditional sources that you or I might have before. Some people are now just tuning into what they like, their brand of information. Social media, it's a lot of different things, but just a high level of distrust that's out there. And so it makes it really difficult. We have, measles is spreading again in America. That's unconscionable, because there's no reason why anyone in America should be contracting measles. But because there's so many people who are saying, I'm not going to vaccinate my kid. It's spreading. Today, people who are dying of COVID are typically folks who didn't get vaccinated or are under-vaccinated. Want me to save your life from COVID? I've got it for you, but you're not willing to, some of you aren't willing to take it. And that's just get vaccinated first and foremost. Treatments are great, but that's, you're treating a condition instead of preventing it and keeping you well. It's so, I'll stop.
No, it's a lot to counter, but you're doing it really well. The only thing I'd say is we have to make certain on the side of government and agencies that we're using the 21st century tools of communication that most folks are on these days. We know that cable viewership is down like 40%, network viewership down 20%, even Facebook has become old-fashioned media for some, and only like there's a 20% drop there. So I think that you and others are being really
I think
creative.
I'm still on MySpace or something.
But you and others are being creative about taking the conversation to where folks are at on the ground. But we also have to make sure in government that we're being as innovative as possible and using the new tools that are available to us. Andre, I know you have one last question from the audience, and then we're going to give the secretary an opportunity to kind of put a ribbon on all of it.
Perfect. And that MySpace comment just threw me back.
Yeah.
Last question. The administration is leading the Advanced Research Projects Agency for Health, ARPA-H, and recently launched the Women's Health Research Initiative. There has rightfully been a lot of discussion recently on who's been historically included and excluded from research. Can you speak more about why it's so important that research participants represent Americans fully and what your department is doing to ensure that that's the case?
Yeah, this is
A great question.
yeah, and this is one of those reasons why it's such a joy to get to work with a great team at Health and Human Services. I think most people have this notion that we haven't done the best job of trying to do research on the entire population, and that we rely too much on research that's done on one segment of the population, typically white males. To the point that there was research that was done to deal with women's health issues, or issues that affected women far more than men, that included trials that only included men. And so it's kind of crazy, but that's where we were. Thank God, again, the president has pushed. ARPA-H is an agency that the president pushed to create. We got $1.5 billion to seed the agency. ARPA-H essentially, you've heard of DARPA, the agency that supposedly created the internet and GPS. It's the Defense Department's go-to research agency when they need to get something on the ground. ARPA-H is our counterpart to do health stuff. And essentially what we do is we're going to give out money to a lot of projects, ideas. Some of them will fly, many of them won't. But this is like, we're like angel investors for good ideas that can't find the capital to launch. And unlike NIH, which goes 10 to 20 years on a research project before they come out with a great solution, ARPA-H is 2 years, 3 years. And if it doesn't fly, we move on. But what we want to do is catalyze those ideas that are out there that may be small in hit or knowledge, but could have dramatic impact. So the very first program that ARPA-H put out, can the body regenerate its own tissue? So think, you got a bum knee. Rather than have surgery, let your body regenerate that tissue. You know how many people who have to miss work, have to give up being active, could benefit from not having to worry about losing their tissue. You got the disc that's rubbed down in your back and now makes it impossible for you. You think about it, that if that hits, you and I are going to be like, wow, wintertime and I can still move. It's like, this is pretty good. ARPA-H is all about that. ARPA-H is investing $100 million to do women's health research. Women's health research. We're looking for the best ideas, sort of like Shark Tank. Best ideas, you will get some money. And then you have 2 or 3 years to get that baby off the ground. And what we're hoping to do is move into the space that is relevant to female health, because we've never really done that. And I thank the First Lady, Dr. Biden, for really pushing this so hard. Maria Shriver, who obviously some people know, she's very, people know her well in California, was very much behind this, because she's always said, we've never done enough research for women, especially menopausal women. And so she's really pushing the envelope, and $100 million sounds like a lot of money. It's going to go very fast. But if we hit on some of these things, ARPA-H is going to fly.
I'm trying to picture you as the Mark Cuban of medical research, standing up in front of the Shark Tank room, giving folks an up or down. Mr. Secretary, we have your back in these negotiations. We're rooting for you here. This is critically important. We're grateful to you for your leadership. I wonder if you have any parting thoughts or parting words before we just commend you.
Yeah, and I hope I don't lose you. And this crowd may understand it more than others. I always get asked everywhere I go. It's always the same. We need more money for our healthcare clinic. We need to open up another hospital wing. We need to bring in more doctors. We need to have more nurses. Give me some more money. So always they want more money. And we need you to make it so that doctors can practice through telehealth. Everyone thinks that the Department of Health and Human Services runs healthcare in America. I want to surprise you. We don't. And that's because nowhere in the Constitution will you find where it says that the federal government and the Department of Health and Human Services run healthcare in America. It helps you understand why the Affordable Care Act went before the Supreme Court 3 times, because healthcare is not a federal function. It's a state function. And so for the federal government to get into the healthcare game, we have to give money. Medicare is the perfect example. Hospital, you want some of my Medicare money? You got to open the door to a whole bunch of folks who are indigent. Doctor, you want to get reimbursed from Medicare? You got to make sure that you do certain services. We are in healthcare because we put up money. The Affordable Care Act, same thing. We're in that game because we put up a ton of money. Medicaid, we pay this. States run Medicaid. We give them about half of the money, in some cases more than half of the money. To do Medicaid, they got to follow our rules. That's the way we get in the game. You saw what happens when you don't have a national system of health or public health. COVID was the best example of why we can't continue to do it this way, because you've got gaps. One state will do it well, one state will not. And you got 50 different ways of doing COVID. You got 50 different ways of doing Medicaid. You got 50 different ways of doing prescription drugs and the rest. It doesn't work. And the folks who always fall through the cracks are the same people we talked about earlier. And so what I hope you will know is that we need to make a concerted effort to not treat healthcare like a nationwide system, but a national system that it's seamless, so that regardless of where you go, you won't suffer. Probably the best example today of a nationwide system of healthcare is reproductive healthcare, because you can go from one state and cross the border of that state into another state, and your care is totally different and your rights are totally different. How that exists in America, I don't know, but it's harsh, and we got to change it because our lives depend on it. And COVID was the perfect proof. No one is safe until everyone is safe. No one is perfectly healthy until everyone can be perfectly healthy. We live in a village, and we got to take care of each other, and we can't have this commoditization of healthcare so that only those who've got money get the healthcare.
That's the perfect mantra to send us off on. I think it's time, Mr. Secretary, for you and I to go get that champagne I promised at the top. Thank you so much for the conversation, for being the first secretary to christen our new event space. Appreciate you all and the thoughtful questions from our audience.
Thank you all very much.